unmute rồi đấy. Ok, thế được rồi. Nhưng mà chỗ thầy Lợi phải chú ý.
we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
Good morning, good afternoon, and good evening. Dear distinguished guests, colleagues, and friends, it's now time for the opening ceremony of the 14th Congress of Asian Society of Cardiovascular Imaging, Asci 2021 at Hanoi, Vietnam. I'm Dr. Nguyễn Ngọc Tráng, General Secretary of Asci 2021 Congress. Welcome all of you to the 14th Congress of Asci 2021. At Vietnam, which we held totally virtual due to the pandemic of COVID-19. The first part of the opening ceremony will be the speech from the President of Asci, the President of the Vietnamese Society of Radiology and Nuclear Medicine, and the President of Asci 2021 Congress. The second part will be the Asci Awards, and the final part will be the group photo. Now, I'm very honored to invite Professor Yu Liang Wan, the President of the Asian Society of Cardiovascular Imaging, to deliver the declarations of opening. Professor Wan, please.
Yes. Can you hear me clearly?
Yes, very clearly.
Thank you. Dear colleagues, friends, members, and officers of Asci, good morning, good afternoon, good evening. On behalf of the Asci, it is my great honor and privilege to give an opening remark and welcome all of you to the 14th Congress of Asci. From now on, Thursday to Saturday, the Asci 2021 will be held in hybrid form at Hanoi. Hanoi is the capital city as well as the second largest city of Vietnam. The Asci Congress is held every year. It has been held twice in China, Japan, Korea, Singapore, and Taiwan, and once in Hong Kong, Malaysia, and Thailand. In addition to the annual Congress, the Asci has been playing a significant role in the education and research. Accomplishment of Asci include the publication of an official journal, the CVIA. The Asci School to train and foster intelligent and young generation. The theme of Asci Congress this year is Beyond the Future of Cardiovascular Imaging, Opportunities and Challenge. The Congress will provide inspiring refresh course and update scientific program, including the implication of AI in cardiovascular imaging. It is Asci's privilege to collaborate with sister society, including the ESCVI, ESCR, NASCI, SCCT, and SCMR. Outstanding speakers from those sister societies are invited to strengthen the scientific program. Due to the global pandemic, international professionals of healthcare are cordially welcome to join the virtual meeting. I'd like to extend my sincere appreciation to the Congress President, Professor Hong Ming Lloyd, the President of VSRNM, Professor Tong, and all the LOC members of Asci for organizing this extraordinary Congress. I would also like to take this opportunity to thank all the participants, speakers, moderators, officers, and members of Asci, as well as the industrial sponsor for promoting the advance of cardiovascular imaging and the forthcoming success of the Asci 2021. I hope, and I also believe, that all of you will enjoy and learn a lot from the scientific program, which is well organized and attractive. Have a nice day. Thank you very much. Thank you.
Thank you, Professor Wan, for the impressive declarations of opening for the Asci 2021. Up next, I'm glad to invite Professor Phạm Minh Thông, the President of the Vietnamese Society of Radiology and Nuclear Medicine, to deliver the welcome speech. Professor Thông, please.
Good morning, dear colleagues and friends. On behalf of the Vietnamese Society of Radiology and Nuclear Medicine, VSRNM, it is my great honor to welcome you to the 14th Asian Congress of Cardiovascular ASCI 2021. This time, ASCI Congress will be held in our beautiful country, Vietnam. However, due to the outbreak of the COVID-19, we could not welcome all of you to join us in person. Overcoming the challenges, our local organizing committee have held the ASCI 2021 Congress totally in virtual for the first time. I would like to express our delighted announcement that this year, it is our 60 years of the Vietnamese Society of Radiology and Nuclear Medicine, who mark the development of VSRNM in the field of radiology and nuclear medicine in Vietnam. Right after the 3-day Congress of ASCI, the 22 annual Scientific Congress of VSRNM will be held online on August 22. I would like to express my sincere appreciation to the President of ASCI, Professor Zhang Linyuan, Congress President, Associate Professor Hoàng Minh Lợi, and the local organizing committee member of ASCI 2021 for organizing this amazing Congress. I also would like to take the opportunity to thank all participants, speakers, moderator, colleges, fans, association, the sponsor companies for promoting and support the success of the ASCI Congress 2021. With all of you, the best of luck and health. Thank you.
Thank you, Professor Phạm Minh Thông, for the warmly welcome speech. Now, I would like to invite Professor Hoàng Minh Lợi, the President of the Asci 2021 Congress, to deliver the greeting speech. Professor Lợi, please.
You hear me clearly?
Yes. Yes, we can hear you, Professor.
Okay. Ladies and gentlemen, good morning, good afternoon, and good evening. Dear distinguished guests, colleagues, and friends, warmly welcome to Asci 2021 Vietnam. It has been a great honor to meet all of you in the virtual 14th Asci Congress. On behalf of local organizing committee, I would like to thank you for your interest and participation in the virtual Asci Congress 2021. In this year, Vietnam and many Asiatic countries and over the world overcoming the difficulty of COVID-19 pandemic. We must hold the Asci Congress totally online combined between Asci and VSRNM, between VSRNM and Vietnam National Heart Association, VNHA. In the recent year, our imaging has become essential in both clinical practice and research. The theme of Asci 2021 is beyond the future of cardiovascular imaging, opportunities and challenges. With the current COVID-19 pandemic, everyone should get used to new normality. We hope this virtual congress will give you and other eminent professors from over the world and doctors from Asian countries the opportunity to share knowledge and to exchange experience in the field of cardiovascular imaging. Together, we have built an agenda include inspiring educational courses and sensation scientific program. Gradually get acquainted with the virtual exhibition booth of sponsor company industry. I would like to give my deepest thanks to Professor Young Ling Wan, President of Asci, Sister Society, SCMR, NASCI, ESCR, SCT, ERCBI, Professor Pham Minh Thong, President of PSRNM, and VNSA Association for your contribution on our scientific program. Thank you for faculty, chairman, lecturers have arranged your time to connect and join in our congress. Sincerely thank all AOPO officers of Asci for your devote to successful of this congress. Finally, I would like to send my appreciation to sponsor company with Bayer Platinum sponsor, Rico Silver sponsor, Canon Bronze sponsor to continue to this great event. Once again, thank all of you for your participation, and I wish you will have a great time to 3 days on the Asci Congress 2021. I wish the Congress will be have successful. Thank you.
Thank you, Professor Hoàng Minh Lợi, for the greeting speech. The next part of the opening ceremony is Asci Awards. The first
On behalf
one
of the nominating
in the Asci
subcommittee for Outstanding Award, we would like to announce Outstanding Award goes to Dr. Teruhiro Mukizuki, Emeritus Professor, Department of Radiology, Ehime University School of Medicine, Ehime, Japan. Radiology Professor, Sechenov First Moscow State Medical University, Moscow, Russia. And now it's time for Dr. Teruhiro Mukizuki's speech.
Dear colleagues and friends, I am very glad to receive this Asci Outstanding Award and so nice plaque. Here I look much more handsome in my plaque. It's a great honor for me. I thank all the Asci colleagues and friends, nominating committee and the chair meeting, Asci EC members, Asci Congress President Dr. Loy, and Asci President Dr. Wang. In 1996, that is 10 years before the Asci founding, I started cardiac CT using a single detector CT. Since then, I was playing the CT with my colleagues' Ehime cardiac team. Without their cooperation, my achievement would be very limited, so I thank my colleagues in Ehime too. Through Asci, I could make many friends. That is most important thing and my treasure. I also appreciate Asci office so much. Their administrative support is so excellent. We have so nice Asci homepage and Asci journal. And I respect the enthusiasm of the Asci colleagues to do something for the young colleagues through Asci Congress, Asci Square, Asci Cube, Asci Journal, and so on. Congratulations for the 14th Asci Congress. I'm sure this online meeting would be very successful. Let's enjoy Asci Congress. Thank you again.
Thank you. And congratulations, Dr. Teruhiro Mochizuki, for his dedication and contributions to the advancements of the society. Up next is the 7th Asci Gold medalist.
On behalf of the Gold Medal Nominating Subcommittee, we would like to announce the 7th ASCI Gold Medalist goes to Professor Dong Huynh Yang, Asci Medical Center, University of Ulsan College of Medicine, Seoul, Korea. And now it's time for Professor Dong Hyun Yang's speech.
Hello, I'm Dong Hyun Yang from Asci Medical Center, Seoul, Korea. It's a great honor to receive the gold medal in the Asci meeting 2021 Vietnam. As you all know, Asci has been the center of cardiovascular imaging activity among the Asian countries. I'm very proud of being an Asci member and gold medalist of the Asci. I want to be a meaningful contributor to the Asci in the future. Personally, I would like to express high appreciation to the Professor Tae-hwan Lim, the founding president of the Asci, the great leader of my department and hospital, and a great teacher of mine. He always gave motivation to me in my academic and personal life. Also, I would like to appreciate Professor Junwon Kang and Hyun Jung-gu in my department for their great support and kind understanding. Finally, I thank my son Seong-uk and my wife Jung-min. Thank you.
Thank you and congratulations, Professor Dong Hyun Yang, for his outstanding academic achievement. Now we come to the last part of the opening ceremony, the group photo. Dear distinguished guests, colleagues, and friends, please turn on the camera and stay tuned with us. I will count down 1, 2, 3. Once more time. Now we will say Asci. I will count out again. 1, 2, 3. Asci.
Asci.
So thank you so much for your kind attention for the opening ceremony. The opening ceremony is end now. And up next is the plenary section. And we would like to invite Professor Tae-hwan Lim from Korea and Professor Phạm Minh Thông from Vietnam to chair these sections. So please enjoy the scientific program. Thank you.
Good morning. I am Dr. Phạm Minh Thông, Professor of Diagnostics and Interventional Radiology of Hanoi Medical University, President of Vietnamese Society of Radiologists and Nuclear Medicine. It's my great honor to be the chairman of this session together with Professor Tae-hwan Lim. He is President of National Academy of Medicine of Korea. The name of this plenary section is Beyond the Futures of Cardiovascular Imaging, Opportunities and Challenges. This session accompanied with bio. For the first topic, the future and challenges of the cardiovascular imaging, I would like to introduce Dr. Lord George Shim, Professor of Radiology, Head of the Department of Diagnostics and Interventional Radiology, University's Medical Center, Göttingen, Germany. Professor Lord George Shim, please. Do you hear me? Professor Lord Shim? Not sure him? Not sure him? Hello?
Contrast agent injection could probably be avoided in the future. This is another paper. This is the paper that tried to achieve the same goal, but instead of using texture analysis, these authors looked at motion patterns of the left ventricle and tried to link this to the presence or absence of left ventricular scar tissue. And what they found was that both for subendocardial MIs as well as transmural MIs, the algorithm performed very nicely. So you can imagine that if you combine the texture analysis with this method, you could probably even get better results for the detection and classification of left ventricular scars. Here's some work from our group, switching back to CT again. So this is a deep learning method that aimed to basically identify flow-limiting coronary stenoses in cardiac CT scans. So what we did here is we created a network that aimed to identify patients with FFR positive and negative stenosis. So what we did is we created a network that segmented the left ventricle, and we trained this network based on the data of 166 patients, 40 of which were used for development, 126 for validation. And what we did is we trained this network with known FFR values, and then we tested it on an unseen set. Good morning, my name is Tim Leiner, and today I will be speaking about artificial intelligence in cardiovascular imaging. I would like to start out by thanking the organizers of Asci for the opportunity to give this keynote lecture. It's a tremendous honor, so thank you. These are my disclosures. And in this presentation, I will walk through several themes. I will start out with describing my work as a radiologist today, because this will identify opportunities for artificial intelligence in cardiovascular imaging. Then I will walk you through examples of how machine learning can potentially help improve patient care. And then finally, I'll finish up with talking about how we can bring machine learning to the clinic. So let's start out with my work as a radiologist. So when a radiologist is coming into the picture, or a cardiovascular imager, if you will, this already starts in the process where the cardiologist or another doctor is talking to the patient. Because when imaging is considered, there are several things that you need to weigh before you decide whether or not to refer the patient for an imaging test. And machine learning can already help to identify markers or medical information that can help the clinician decide whether or not it's useful to send a patient for cardiovascular imaging. So this is one opportunity. It even starts before the patient is referred to imaging. So once a decision is made to refer the patient to imaging, as is the case for this lady, there are many opportunities in the image acquisition process before the images are even made to improve this process by machine learning. So I will show you many details about this later on in the lecture.
Ladies and gentlemen, thank you and welcome to this session and the talk to the future and challenges of cardiovascular imaging. Thank you for inviting me to the Asci 2021 in Hanoi, Vietnam, and I hope I will be able to visit Vietnam in the near future to really see how lovely that country is that is now hosting the Asci 2021. Talk about future and challenges of cardiovascular imaging. If you're talking about future developments, it's a little bit like the future you see foreseen, for example, in Back to the Future Part 2. In that movie was launched in 1989, and I just got this flip from that hoverboard Marty McFly uses to go over water. And if you look at that image closely, as we do as an imager, you see that Marty McFly isn't really happy on that hoverboard. But it was prognosticated that in 2015, we will be able to have those hoverboards and moving around without touching the ground anymore. The thing is with prediction of future developments is that we all hope that they are kind of a self-fulfillment. the problem is that this self-fulfillment cannot be predicted precisely. So it can happen that you kind of see a realization of that prediction as this e-foil, which you can buy for really a lot of money in the free market. But the exact variation of your prediction cannot be foreseen for sure. So as you can see, this e-foil does look like the hoverboard in Back to the Future Part 2, but it actually works quite differently with an electric motor beneath the surface of the water. I think this is the principal problem of predictions of the future. So best is to start with the present. We have seen a change in cardiovascular imaging guidelines in 2019 by the European Society of Cardiology. And this was a kind of a breathtaking change because EC poses an morphologic imaging modality, the CT, as a first choice for imaging the heart in patients with angina after a certain workup. And we have to have a short look on this workup because after clinical assessment and the rest echocardiography to really rule out severe emergency and highly important, highly emergency changes in the cardiac pathology, we see this assessment of the pre-test probability and clinical likelihood of coronary artery disease. And if you look at how this probability has been structured by the ESC, you see that the age from which on you say that a non-invasive testing modality is beneficial has moved up. Basically spoken, a woman patient with nearly 70-year-old with the presentation of atypical chest pain will have a pretest probability of a coronary obstructive disease of just 11%. So she will not qualify for an advanced non-invasive testing. Whereas a patient of my age with a typical pain and male will actually qualify. So let's go further to a classical example. We have a patient, 52-year-old, who presented to the emergency department with a new onset of chest pain. He was a heavy smoker. So he has critical points and high test probability. If you go back to that table with the pretest likelihood, you see he's 52-year-old. He has a typical pain, 32% probability of obstructive coronary artery disease. So a non-invasive testing is beneficial. And we did that, and good for him. We detected a highly stenotic non-calcified plaque in the proximal LAD, and he surely was transferred to the cath lab, received a PCI with a stent placement, and now is in a life-changing intervention to modify his lifestyle for the prevention of further MACE. Now, if you see how this actually changes the scene in the emergency department, it's easy to predict that calls will arise that we offer this cardiac coronary CT not only 9 to 5, but as a 24/7 service in the emergency department setting. And the problem is also that if you look at the reality life in an emergency department, it's not only the ruling out coronary artery disease, but it's also the rule out of pulmonary embolism and aortic dissections, mostly within the same patient. So the triple out theme is there again. It's like an old theme visited, not really, as you can see here in PubMed, because it's still 2021, just 2 publications out on that theme. But it's there again, the old theme revisited. So can we do this? Is this realistic? Or how realistic is it that we can, in the emergency department, establish 24/7 service for cardiac CT? It's an old question, but it changes. For sure is you need a high-end scanner. Without that, you don't even have to try it. The second truth is you need a sufficiently trained team, techs and medical doctors who are available to work on the tachycardia control. of the patient, because that's the key. Of course, scanners are getting better and allowing high quality coronary CT images even at higher heart frequencies, but the lower the frequency, the better the images still. And there are different publications out there in the market who address this problem. One very positive one is just published in the Emergency Radiology in 2021 by Russo et al. From Bologna in Italy. And they say once you have trained the technique of tachycardia control and the basic technique of coronary CT within the emergency department team, imaging team, the rest is easy. So they made a study where they compared the diagnostic performance of a cardioradiologist, a senior radiologist, and a junior radiologist, and the senior and the junior radiologists were not specially trained radiologists for cardiovascular diseases. And in the rule out of coronary artery disease, the non-trained, non-cardiovascular trained radiologists performed pretty well. They even went further and said they don't even need a very specific software to look at coronary artery disease, to look at the coronary arteries. But the normal multiple plane reconstruction reformatting software is sufficiently enough. On the other side, it's not really on the other side, but another aspect is a study from the group of Joe Schöpf from Charleston. They made a study on CT FFR and coronary CT in the emergency department. And the interesting part is not that it worked with the FFR on coronary CT. We all expected this, and this is a very, very good publication, very thoroughly done. The interesting part is if you look at the patient population. They initially screened more than 270 patients for this study, and about 38% of these patients were excluded because of issues with the image quality. And if you dig into the details, you see that only 2% of them received sublingual nitro, and only 8% received beta blocker to control tachycardia. So you see, technical things do matter. So you need to train the techs and the medical doctors, radiologists or medical doctors in the emergency department, that they are able to control tachycardia if you want to perform a coronary CT within that setting. If then you can do this, it seems to really work nicely, and we're actually planning to do exactly this. Now, why this ESC guideline really works so well, the new one, is that today the most image studies we perform is to rule out coronary artery disease. So their imaging is really strong. And you saw that with that study from Bologna, that even the non-cardiology trained radiologist is good at ruling out coronary artery disease. This is about 80% of the patients we see in the emergency room. The problem starts is if those patients have coronary artery calcifications, plaques, modifications. You see here, down there, you see CTO, so the chronic total occlusion of the right coronary artery. And it's pretty tough to look at these images and really be sure whether this area here is just a blooming calcified plaque or really is an occlusion of the coronary artery disease or not. So what happens is, or what is the challenge is, we need to have more power to really pull in or have an exact characterization of coronary artery disease within CT or MRI, especially in the CT. And so there are two components which we need with speed and resolution. Resolution, because we need to look at smaller arteries also. We need to have high resolution for plaque imaging, which is important, which I will not address in this talk, but which is important, especially for risk stratifications. Resolution also with contrast resolution is important for plaque imaging for myocarditis, which will be in the CT, but also resolution speed is for the critically ill, because tachyarrhythmia will be part of those patients where we want to rule out coronary artery disease. And if we do want to do it with a high accuracy and reliability, we need to increase the speed in terms of reducing motion artifacts or motion sensitivity. And there are different developments out there on the market. So imaging must be strong in rule in the exact characterization of CHD, and we need to have less motion sensitivities in our scans. There are different techniques out there, and there's a very excellent and worth reading editorial on this or review on this in Investigative Radiology from January last year by Michael Lell, where different techniques for motion correction are presented. One of them is a partial angle motion correction, which all work in the CT raw data space to really foresee and calculate the motion expected in the next angles of CT scan and correct the motion accordingly. And you see the success of such an PAMOCO protocol here in the images copied from that publication. So there are techniques out there, and there are different ones from each big vendor, and we'll see this in the future. If not, they are already within the product lines of the vendors. So this is surely one big theme to reduce motion artifacts in coronary artery disease if we want to go to high throughput coronary artery imaging by CT in the emergency department settings. The other part is resolution. Resolution is always linked to X-ray dose, because resolution and noise is somehow linked. We do see new developments of photon counting detector CTs. The first commercially available machines are out there in the market by 2021. And one technique is the photon counting detector by a big German vendor. And the first publication here from Stanford, from Dr. Sanford in JCCT, shows it pretty nicely that it's kind of a next generation resolution in this ex vivo human heart experiment, where a cadaveric human heart was taken and imaged with a standard integrating detector and with a photon counting detector. And you can see that the photon counting detector can go into a next generation high resolution imaging, which has not been able to be realized with a standard integrating photon detector by the conventional CTs we have now in the market. So there is something ahead going now in the very, very high end machines, and we hope that they come slowly down to the normally priced machines in the next years. But this is surely the future in the detector technology, which also has implications in tube design, etc. So it's a really disruptive change in the CT technology, which we actually witness here. Now I've told you that we need speed and resolution to increase the reliability and the speed of coronary artery disease detection in the coronaries. But what we think is that the pure visual assessment of CT and MRI of the coronaries, or simply the MRI of the myocardium, is a dead end. And we need the next step in the assessment of the myocardium. The principal challenge is that most diseases, they take part in this area. This is the myocardium. The epicardial coronary artery disease, they're just in this thin layer here on the top of the myocardium. So, but what really matters is the disease of the myocardium and the myocytes in the extracellular space. So to have a method to do this really thoroughly at high resolution, this I think is the biggest change and biggest challenge for cardiovascular imaging in the next years. We all know that the mapping technologies, T1, T2, T2 star, extracellular volume ECV, there is this lovely and I guess most cited image on the abilities and promising tool of tissue mapping for different sites of pathology in the myocardium. It's all worth the trouble doing this, although we know that T1 is highly variable, it's not standardized well, and this kind of is a big hurdle to put it into daily practice on a wide scale. There are developments out there which might change this. One of them is the MRI fingerprinting. This comes from Joubert, King's College in London, publication in 2021 from JMRI, where they show a very nice Dixon-based fingerprinting technology resulting in a 15-second breath hold per slice, where you get an totally, absolutely co-registered T1, T2 maps, fat map, and if you do it twice before and after contrast injection, you can actually have calculate ECV, can calculate late gadolinium enhancement images out of the same data set, which you take in 15 seconds and which are perfectly co-registered. This might resolve a lot of problems in terms of standardization, reliability of the mapping technology, and it's all goes into the theme of tissue decomposition, so that you characterize in a very thorough way the status of the extracellular tissue as well as the myocytes and their interaction. And there is even another application which we have been longing for a long time, that is myocardial diffusion imaging. This is a publication from last year from Dr. Kalik, which is from the competition in London, from the Royal Brompton. And they nicely show what you can do with myocardial diffusion imaging nowadays. This is an in vivo study, so it's applied to the living, and they showed that with the diffusion imaging at the heart, you can actually discriminate between normal hypertrophic cardiomyopathy and amyloid. In contrast to in contrast to diffusion imaging, which we know from oncology, where we used to use it for viability and for tumor infiltration, myocardial diffusion imaging is more or less a quantitative tissue decomposition, where you assess the interaction between ECV and myocytes. So it's a kind of a functional quantification of the myocyte ECV interaction, which is a totally new approach to tissue decomposition and towards myocardial disease. I think we will see a lot of publications based on a variable implementation of diffusion imaging, but it sure will embark as a non-contrast method besides the classical T1, T2 tissue mapping techniques we are using nowadays. So I think a very important development in our market. There is a third area of imaging the myocardium, which is still in infancy. That is the origin of arrhythmias. You all know the hype in about 10 years ago about substrates for atrial fibrillation, late enhancement in the atrium with very special software, a specified company in the United States, which earned a lot of money for that. And a lot of groups cooked similar programs in MATLAB and sequence programming. We also did that in Göttingen. But it's only limited use actually in daily routine. The problem is that we are not really sure, even with late enhancement of the left atrium, where comes the arrhythmia we are trying to heal. And so there's still no really imaging substrate for the origin of arrhythmias. There are some ideas, and we have one of them. We are glad about this. Stefan Luther in Göttingen, in Germany, in the town where I'm working. They are looking at high-resolution optical cameras, ex vivo, and high-speed, high-resolution ultrasound probes to look at the very subtle movements of the myocardium during systole. And with that, he's able, or this working group is able to visualize arrhythmic re-entry areas, which they call vortices, in the myocardium, and that these correlate intensively with the origin of arrhythmia, opening up a totally new possibility to look at ventricular and even atrial arrhythmias and therapeutic strategies to ablate them. So this actually is very far down the road, but I think it's an area where we are looking at very closely, and we are trying to catch up with at least with the real-time MRI to tackle this important problem. Now, a totally different aspect is the future of cardiac imaging in the whole picture of medicine. We are traditionally, and I include myself there, as a cardiologist or cardiac imager, we believe that the heart is the center of the universe of the human body. Human body does not work without the heart. We slowly realize that there's a little bit more than the heart within the body. So the heart seems to interact with the rest of the body. Well, this is quite wisdom shared among our community in the last couple of years. The first part of, or the first manifestation of this new insight into the interaction between the heart and the body is the heart and brain theme. It's not very new, it's about 10 years old, but it's taking up speed. We all know that the heart has its own intrinsic nervous structure, which is visualized on this slide. So it's a very intense, very closely knit network of neurons within the atrium and also then within the myocardium. We also know that we have a communication road between brain and heart, which on the one side goes over the autonomic nervous system, sinoatrial node, atrioventricular node, bundle of His. They have close connections to systemic, sympathetic, and parasympathetic nerve structures. And on the second part, we have an humeral component where we have a talk between the brain and the heart over the adrenal glands and pituitary glands, which kind of complements the communication structure between the heart and brain. So is this all academic? No, it's pretty realistic that this really interacts. And we know from stroke that certain areas of stroke, of bleeding, result in certain increase of the verisimilitude of cardiac abnormalities listed here. So brachyarrhythmias, sudden cardiac death, wall motion abnormalities, heart insufficiencies. To put it in really very clear numbers is that we know that arrhythmia causes stroke. So if we have patients with a stroke, we know that in 20% approximately, they have a known atrial arrhythmia. And if you have an atrial arrhythmia, we know that you have a kind of a 5 times increased risk for a stroke. The other truth is that stroke causes arrhythmia. So if you talk to your emergency, to your intensive care crew in the neuro, they will talk you. They will actually agree that We have a lot of people with a stroke, especially in the insular region, that induce arrhythmias. And actually, it can be as worse as an AFib. And if you look at the incidence, it's almost with a big stroke, almost all patients have arrhythmias within the first 7 to 10 days after the stroke. So stroke causes arrhythmia. There are some other truths published. One of them is heart failure induces cognitive impairment, and the other way around. If patients with severe heart failure receive a left ventricular device, we know that their cognitive competence increases again. We do not know what is behind that. What's the truth behind heart failure and cognitive impairment? Possibly it's because you might have multiple small strokes by emboly, microemboly. You have hypoperfusion of certain areas in the brain which are more or less sensitive for hypoxia and hypoperfusion. But this all does not explain well other things we see in patients with heart failure, like sleep apnea, arrhythmias, hypovolemia, and the increased concentration of neurohumoral messenger substances in the blood. So it's still an ongoing debate, but it's worth engaging there. And actually, we are building a whole research building just for this case or for this theme about heart and brain interaction, because it has a lot of layers. It has a lot of knowledge still and to take up. One very interesting aspect is that a cardiomyopathy we all know very well, which is the Takotsubo cardiomyopathy, seems not to be a cardiomyopathy, but more or less a kind of a neurocardiac syndrome. Now it's seen that Takotsubo cardiomyopathy has a pretty high incidence in during general anesthesia, which is reversible, of course. We know that there is a theory that this apical hypokinesia, which you can see here, is induced by a kind of an oversaturation of beta-2 receptors within the apical area of the left ventricle. And there are even studies out there in a young patient, which is the case report published in 2017 with different nuclear medicine methods, where it could be shown that also we have normal perfusion in apical ballooning, we have an abnormally decreased glucose metabolism and an abnormally increased sympathetic activity in the apex of the left ventricle in a patient after hypoglycemic shock, which actually supports the theory of a centrally induced, so a neuro-induced cardiomyopathy in the heart. Another part of heart interaction with the body is quite younger, which is the cardiac oncology. Cardiac oncology embarked as an own field in the last 3 to 4 years, because it's seen that the success of oncology therapies result in survival of oncology disease about 30, 40 years. Look at leukemias, lymphomas, and other diseases. And we now see that a late onset pathologic changes within the cardiovascular system, which include coronary artery disease, which include pulmonary hypertension, which include myocardial fibrosis. And cardiac oncology is set out to look at 2 different aspects. First, for an early detection of cardiotoxicity during and late onset after treatment during the surveillance area, and also to identify patients at risk to develop a cardiotoxicity with a specific oncologic drug to be administered for their disease. All in all, to have a kind of a personalized oncologic regimen which minimizes the risk of a late onset cardiotoxicity. It's a new field. It's pretty interdisciplinary. It's pretty cool, with more and more basic research coming into that area. And MRI is by most of the involved cardiologists seen as the most promising imaging modality for this kind of questions. Now, if you consider how many patients we receive daily for the assessment of cardiac function before the start of an oncologic therapy, there are quite a lot. They're usually now examined by echocardiography or nuclear medicine. If you all believe, or if all believe that MRI is the better choice, we'll have a problem with our resources. And that's why, for example, Sanderson, in a very nice, again, a very nice review in the European Heart Journal from this year, he actually proposes a very short, very specifically tailored MRI protocol for just the detection of cancer treatment-related cardiac dysfunction, which is about 15 minutes, which is, kind of the normal slots we have in MRI, which are regarded to be economically sensible. So this is something we have to work at, and we have to address, and we have to be aware of that there will be huge mass of patients potentially be available for MRI assessment of cardiac function, but also tissue decomposition and including strain analysis for the detection of early cardiac toxicity during and after oncologic treatment. And within that review, there is a very nice table on cancer drugs and their possible harm to the cardiovascular system. And as you can see as a whole picture, not going into the details, but if you look at the whole picture, you see that almost every cancer drug does some harm potentially to the cardiovascular system, whether it's myocarditis or valvular disease or pericardial disease or heart failure. So it's a theme. And that's why cardiac oncology is a future aspect that is worth engaging. Now, coming to the end, future is bright for cardiovascular imaging because it's taking up more importance in the field of medicine, in all fields of medicine, and the chances definitely outrun the challenges. We have two main issues. The first is we need a high-resolution tissue characterization, and high resolution is both temporally and spatially. The second point is that we see that the heart interacts intensively with the body. We know that systemic diseases like rheumatoid arthritis or vasculitis do affect the heart. And this interaction and this systemic or the integration into systemic disease offers new opportunities for integrated imaging between the heart and the rest of the body. Now, if you engage into that future, which is bright for cardiovascular imaging, make sure that you do not forget your basic research or your basic sciences in your research. And our basic sciences are not exclusively, but very intensively the bioinformatics, the applied maths, and data scientists. Be sure to make contact to them in your vicinity where you do your research. Now, this is the end, and what I did not talk about is the AI, so artificial intelligence and cardiovascular imaging, but you have such a highly qualified next speaker here, Tim Leiner, and he will tell you all about it. So stay tuned, enjoy, and hope to see you again next year in person. Bye-bye. Greetings from Göttingen in the mid of Germany. Bye-bye.
Thank you so much, Professor Ross Joachim, for your amazing, beautiful, amazing lecture of the challenges and the futures of cardiovascular imaging. We should have many questions from audience about this very interesting topic. But the time is very limited, so we move the discussion at the end of the session. Okay?
Okay, thank you.
And also, William, please.
Okay. Professor Tom, shall I start now?
Yeah.
Okay.
Please.
Thank you very much for your nice introduction. And it was a really nice, fantastic, and futuristic lecture done by Professor Lutz. It's really nice. And I am Dr. Lim, and I would like to introduce our next speaker. And this is my great honor and pleasure to introduce Tim Liner, Professor Tim Liner, who is a tenured professor in Utrecht University and Medical Center, chair in the cardiovascular imaging in the same institution. And as you can see here, he did lots of things in cardiovascular imaging, but uniquely, he spent 18 months in Boston with Dr. Warren Manning as a postdoc in the Beth Israel Deaconess Medical Center, Harvard Medical School. And he has served 3 years in voting trustees of ISMRM and SCMR. And he is now a president of ISMRM. As you know, Dr. Tim Liner's topic today is artificial intelligence. He's a former speaker talk about the technology itself of the cardiac imaging, and now we turn our sight into the world of AI. So, Dr. Tim Liner, please.
Good morning. My name is Tim Liner, and today I will be speaking about artificial intelligence in cardiovascular imaging. I would like to start out by thanking the organizers of Asci for the opportunity to give this keynote lecture. It's a tremendous honor, so thank you. These are my disclosures. And in this presentation, I will walk through several themes. I will start out with describing my work as a radiologist today, because this will identify opportunities for artificial intelligence in cardiovascular imaging. Then I will walk you through examples of how machine learning can potentially help improve patient care. And then finally, I'll finish up with talking about how we can bring machine learning to the clinic. So let's start out with my work as a radiologist. So when a radiologist is coming into the picture, or a cardiovascular imager, if you will, this already starts in the process where the cardiologist or another doctor is talking to the patient. Because when imaging is considered, there are several things that you need to weigh before you decide whether or not to refer the patient for an imaging test. And machine learning can already help to identify markers or medical information that can help the clinician decide whether or not it's useful to send a patient for cardiovascular imaging. So this is one opportunity. It even starts before the patient is referred to imaging. So once a decision is made to refer the patient to imaging, as is the case for this lady, there are many opportunities in the image acquisition process before the images are even made to improve this process by machine learning. So I will show you many details about this later on in the lecture. So once we've acquired the images and the report is being made, you can see myself making a report here, and I look slightly annoyed. And that's because the process of dictating information about what you see in the images is in fact very primitive. We have systems like CAD-RADS that attempt to structure this, but it's still largely a human job where the information has to be dictated into a microphone, where there are errors in the transcription. Alternatively, you can of course type this, but there are tremendous opportunities for machine learning to already start extracting the relevant features from the images before or generating some kind of pre-processed report for the clinician and the radiologist to review. Then we have the area where we acquire information in images that we don't routinely report. These so-called unrequested findings can be very important prognostically for patients, but may not necessarily be relevant to the diagnosis at hand. And this is also an opportunity for machine learning to greatly improve the value of imaging. So if we look at the imaging pipeline, how can we judge the effect of machine learning or AI on medical imaging? Well, in fact, the entire pipeline is fair game for these techniques. So as I mentioned, it starts with indications setting and patient scheduling. There are opportunities for AI in the field of acquisition, in terms of raw data processing before images are made. Once the images are made, AI techniques can be used for segmentation and quantification, and this is the area that most people associate with machine learning today. Then we have the field of classification and reporting, and finally the field of prognosis, as I just mentioned. And in all of these steps of the image process, AI can and will be applied in the near future. So let's take a look at some of these areas, and I'll walk you through some examples of where I think an impact is already being made or will soon be made in clinical practice. So let's start out with looking at image acquisition. And for those of you who are not clinicians, I want to make a note of the clinical relevance here. So when we talk about MR imaging, MRI sequences are typically too slow. An examination of the heart may take up to 1 hour if it's very extensive, and this is very long. Just ask your patients, they also don't like it. MRI is very expensive because scanners are expensive. They cost 2 to 3 million if you want a scanner that is capable of doing everything you need in the cardiac field. And if we talk about CT, radiation dose does remain an issue. The machines are also expensive, but radiation dose is also a big issue. Many patients receive very high doses still, and there's also an opportunity for AI to help lower that radiation dose and make sure that CT is a safer modality in the future. So let's take a look at some of the developments that we've seen coming out recently. And this is a slide that's given to me by Lon Simonetti of Ohio State University. And this slide aims to illustrate the way AI goes hand in hand with things like cheaper hardware. So this is a cardiac MR cine acquisition, as you can see, in multiple orientations. And I would argue that these images are more than good enough for clinical diagnosis, although they are a little bit noisy. Well, why are they noisy? Well, that's because they are acquired at a very low field strength of 0.35 Tesla. And the noise is something we can deal with. We know how to denoise images. So that's where AI goes hand in hand with facilitating a technique that is much cheaper, i.e. scanning at 0.35 Tesla with good gradients. We can get images in short imaging times of high quality, as you can see right here. There's some other images as well. So also parametric mapping and delayed enhancement can be done using these cheaper magnets. Now, why is this so interesting? Well, because the cost of these magnets is much lower. So the cost to build such a magnet is much, much lower compared to building a 1.5T or a 3T or even a 7 Tesla magnet. So you can imagine that using cheaper hardware will democratize access to cardiac MR, and artificial intelligence can play an important role in making sure that the image quality is up to par compared to the image quality we are used to at 1.5 and 3 Tesla. So this is going to enable using cheaper hardware. Let's move on to image reconstruction. So this is a field where AI is having a big impact as we speak. There are different ways to deal with this. For instance, AI can be used for image enhancement. AI can be used for case-based enhancement before images are made. It can be used to directly convert case-based data into images instead of a Fourier transform. And it can be used to optimize all of these separate steps individually. And what we've seen is a bunch of publications coming out recently in this field that are really showing the potential of these technologies. And I want to highlight a couple here on this slide. And this is work by the group of Daniel Ruckert from London and Munich. And his group has shown that using convolutional neural networks can be really advantageous for speeding up cardiac MR imaging. Because in these two papers, what they basically showed is that convolutional neural networks can be used to reconstruct images from vastly undersampled data. So what you can see on the left side here is a 6 times accelerated cardiac MR, in which the heart is barely visible. In the middle, you can see the CNN reconstruction, and on the right side, you can see the ground truth reconstruction, which takes about 6 times as long to acquire. And I would argue that these images are very hard to distinguish from each other and more than good enough to clinically or use in the clinic. The group has taken this work further and has now shown the feasibility of 11 times accelerated cardiac MR using this method. So on the left, you can see the accelerated reconstruction or acquisition, let me put it that way. In the middle, you can see the reconstruction with the convolutional neural network. There are ever so slight artifacts in the septum, but I don't think they influence the clinical judgment of cardiac function in this patient. And on the right side, again, you can see the ground truth acquisition, which takes 11 times as long as the acquisition in the left and middle panels. So a big boost forward, and these methods can be used on top of conventional acceleration methods for cardiac MR imaging. Also in the field of CT, there's interesting work. So AI is great at denoising, and this is something that can be used advantageously in CT imaging. So this is work from Jelmer Woltrink, one of my PhD students, and what he showed is that AI techniques are great for reducing the dose of CT examinations. So let's take a look at what we're seeing here in this image. So on the left side, what we see, or well, actually, we're looking at a phantom of the heart with a coronary calcification. And what you see if you draw a line profile along this line, or you look at the noise level along this line, the density values along this line, what you see is that there is quite some noise on the line profile. And you can see the jittery excursions of this graph as a function of the position along the phantom. Now, if we use iterative reconstruction, which comes on the system of many modern CT scanners, but at a hefty price tag, you can see that this jitter goes down, which means that the noise level goes down. Now, the same can be achieved by using a convolutional neural network, but I would argue with an even better result. So this network was trained by feeding it with pairs of undersampled or low-dose CT scans, as well as full-dose CT scans, and then the network learned how to reconstruct images as if they were acquired with the full dose applied for this CT imaging protocol. And this is a phantom, but here are some results in actual patients. So what you see right here is a low dose acquisition at 20% of the usual dose, so a low dose with a dose reduction of 80%. In the middle, you can see the iterative reconstruction, which denoises the images nicely. And on the right side, you can see the convolutional neural network reconstruction, which is much faster and much cheaper to perform compared to the iterative reconstruction. And I would argue that these images, again, are very hard to distinguish and that the calcifications look nearly identical. So this is also an example of how AI nicely leads to great advantages for patient care, i.e. a 80% dose reduction for coronary calcium scoring. Here's some other work. AI can also be used to facilitate personalized contrast medium dosing. This is some work from colleagues of mine at Utrecht University Medical Center, and what they did is they used AI-derived body composition measures to adjust the contrast agent dose to achieve enhancement of the liver parenchyma. And this study nicely showed that in many patients we're actually overdosing or underdosing the amount of contrast if we just dose by weight sec. If we dose by lean body mass, we actually get much better and more consistent enhancement, and in the process we can actually save iodine because we are more efficient. For instance, in the Netherlands, where about 600,000 CT scans are done every year, 1.8 tons of iodine could potentially be saved by using this method instead of just dosing by weight. All right, so let's move on to segmentation here. And this is the area that most people think of when they think of AI in clinical practice. And let's take a look at what has been done and why this is important. Well, obviously, this is tedious work because it takes a lot of time. Trained observers spend about 10 to 30 minutes per patient for just a few simple tasks. And as I said in the beginning of this lecture, time limitations restrict routine extraction of all the relevant information that is present in these images. So when we answer a certain clinical question, we usually disregard potentially relevant information in other areas of the body that we could use for better managing our patients. Also, machine learning can help identify poorly visible structures and may actually lead to less contrast injection or complete reduction of contrast agent or omission of contrast agent in certain indications. So let me show you this by walking through a couple of papers. So this is a paper that came out recently in 2019, where these authors nicely showed that deep learning of the left ventricle is basically ready for clinical practice. This was a multi-vendor, multi-center study where the investigators looked at the capability of a machine learning algorithm to accurately segment the left ventricle in comparison to manual measurements. And this correlation was very high, as you can see in these graphs on the lower left side of the slide here. So in the accompanying editorial, the editorial list nicely recognizes the strength of this study, multi-vendor, multi-center. Normally it requires about 10 minutes, but with this deep learning, it takes about less than 1 second per patient. So this is a really big advance, and it will free up time to do other meaningful things instead of drawing circles when we read cardiac MR scans. Here's another example, but in the field of cardiac CT scanning. So this is a paper that recently came out that aimed to segment, using machine learning techniques, the different chambers of the heart, and also using deep learning. So this was developed based on 166 CTA data sets. This was also using a convolutional neural network, and the algorithm was trained to give the left ventricle and diastolic volume, also on the right side, also for the atria, as well as the left ventricular mass. And all of this can be done in a couple of seconds. So these are the results from this paper, and you can see that except for left atrial volume, there was near perfect agreement for all of these parameters with low margins of error. Now, this is a paper from our group, and what we aim to do here is basically the same thing. We aim to segment the cardiac chambers and the large vessels, but instead of doing this based on conventional contrast-enhanced cardiac CT, we tried to do this based on coronary calcium scoring scans, which are acquired without contrast agent, as you know. So these were non-contrast enhanced cardiac CT scans. And what we did is we used a dual energy CT scanner, dual layer detector CT scanner, and we created pairs of contrast enhanced and non-contrast enhanced images out of acquired data. And we use the contrast enhanced data to train a network to segment non-contrast enhanced scans. And as you can see, the dissimilarity coefficients were very good for this task compared to manual measurements. So this work shows nicely that you can use AI techniques to also identify structures that are actually quite poorly visible to the human eye, but can be segmented using proper machine learning algorithms. All right, so let's move on to diagnosis. And what is the clinical relevance here? Well, obviously, a strong point is that machine learning could serve as a second reader and thereby hopefully reduce diagnostic error. Machine learning can also be used to triage examinations, for instance, by identifying ones with abnormalities that should be read first. And machine learning could also perhaps be used to avoid follow-up invasive examinations. I'll show you a couple of examples of that later. And again, we could potentially reduce contrast agent usage. So let's take a look at some of these things. So this is data from a challenge. And for those of you who are unfamiliar with this concept, a challenge is where different groups try to compete in performing a certain machine learning task. In this case, the task was to create a network that could automatically categorize patients in certain disease categories. And this is the result from our submission. And the objective here was that based on a training set of 50 cardiac MR scans with known disease categories, the investigators created a network that would categorize 100 unseen scans in the training process into different disease categories. And the categories were normal scans, scans of patients with dilated cardiomyopathy, scans of patients with hypertrophic cardiomyopathy, scans of patients after an infarct, and patients with right ventricular abnormality. So in total, there were 100 cases. And the objective, again, was to categorize these patients in the correct disease category. Now, this was based on segmentations, and then these segmentations were linked to certain disease categories. And as you can see, the results were not perfect, but they were pretty good for a system that can automatically do this without any human input. And this just takes a couple of seconds using modern GPU hardware. Now, here's another example that is also quite interesting, because what we do currently to detect scar in the left ventricles, we inject contrast agent, we wait 10 minutes, we do a delayed enhancement scan using an inversion recovery sequence. And in the next couple of slides here, I'm going to show you some work of investigators that try to avoid using contrast agent, but try to do this by using either texture analysis of the left ventricle or using motion patterns of the left ventricle. So this work was based on texture analysis, and what these investigators did is they took 120 patients with scars, and they took 72 patients with large infarcts, 48 with small infarcts, 60 control subjects, and they used a single end diastolic cine imaging frame to which they applied radiomic analysis with the objective to try to see whether or not there was an infarct and if it was transmural or not. So they used an open source package that looked at 286 features, and they also tested the reproducibility in 10 subjects. So again, here's the receiver operating curve. These results are not perfect, but they definitely show the potential of this method. The area under the curve here exceeded 0.9, which is very good for all practical purposes and could certainly be used in a situation where a human sort of supplements this with their own take. And then I think that in a large number of subjects, contrast agent injection could probably be avoided in the future. This is another paper. This is the paper that tried to achieve the same goal, but instead of using texture analysis, these authors looked at motion patterns of the left ventricle and tried to link this to the presence or absence of left ventricular scar tissue. And what they found was that both for subendocardial MIs as well as transmural MIs, the algorithm performed very nicely. So you can imagine that if you combine the texture analysis with this method, you could probably even get better results for the detection and classification of left ventricular scars. Here's some work from our group, switching back to CT again. So this is a deep learning method that aimed to basically identify flow-limiting coronary stenoses in cardiac CT scans. So what we did here is we created a network that aimed to identify patients with FFR positive and negative stenosis. So what we did is we created a network that segmented the left ventricle, and we trained this network based on the data of 166 patients, 40 of which were used for development, 126 for validation. And what we did is we trained this network with known FFR values, and then we tested it on an unseen set of data that was not used for the training, and we classified patients as having either an FFR positive stenosis or a negative stenosis. And basically what the algorithm does is it looks at different patches of myocardium and tries to analyze differences between subjects who either have or don't have a flow-limiting lesion. So you can see the results right here in this ROC curve. And again, the results are not perfect. The area under the curve is about 0.75. But this was a small study, and we're now doing follow-up work to try to see if we can extend this to different scanners, more patients, different institutes, etc. So there is certainly some signal in this data that is very promising and that can help us to assess whether or not patients are in need of an invasive coronary intervention. So let's finish off with prognosis here. And what is the clinical relevance here? Well, as I said in the beginning of the talk, most images are made for diagnostic purposes, but they can also contain prognostic information, which could potentially be used for things such as adjusting the intensity of expensive therapies, but it could also be used to identify patients who come with a certain clinical question, but turn out to have risk factors, for instance, calcium in vessels that may indicate the presence of atherosclerosis in patients whom we don't even ask for this or look for this. So this could be a very interesting application, in my opinion, of AI to, let's say, get more out of the images that we make for certain clinical questions. But let's look at the therapeutic implications first here. So this is a patient with pulmonary hypertension. You can see the hypertrophy of the right ventricle. You can see the septal deviation towards the left side of the heart. So this is clearly a patient with pulmonary hypertension. Now, this is a disease with a very poor prognosis, but there are some new drugs on the market, but they are very expensive. These cost about $45,000 per patient per year in the United States. And I'm going to show you this work by Bello et al., which is, I think, a brilliant illustration of how you can use machine learning to get more out of images and come up with new paradigms of looking at this data. So what you see right here is a volume rendering of the right side of the heart, and these loops on the right ventricle represent the motion of these pixels over the cardiac cycle. So you can see that there are some pixels that move a lot, there are some pixels that move very little, and what these investigators did is they took this information on a pixel by pixel basis and put it into a network that tried to predict survival. And what they did is they tried to compared the survival generated, or the survival estimate generated by the neural network compared to conventional MR parameters such as right ventricular ejection fraction or even longitudinal strain. And what they showed nicely in this paper is that conventional MR parameters can, to a certain extent, identify patients who do better than patients who do worse, but machine learning is markedly better at this task. So we are missing information if we only look at the ejection fraction or the strain. And machine learning can pick up this information and identify patients who do much poorer compared to patients who have a somewhat better prognosis. And arguably, what you want is you want to spend your money on the patients who have a poorer prognosis and see if the effect of the drug is better in that group compared to the group that has a somewhat better prognosis. And what these investigators also did is they tried to identify which areas of the myocardium contributed most to the prognosis by doing so-called saliency analysis. Now, here's another example of the same principle. So this is a coronary CT scan of a patient with a complex plaque right here in the circumflex coronary artery. And what we know is that we can treat this with statins and high blood pressure medication, but there are also new drugs that can reduce inflammation, such as canakinumab, but this drug is very expensive and costs $73,000 per patient per year. Now, what these investigators did is they tried to look at other measures present in the images that basically attempted to identify risk factors in the images that conferred a poorer prognosis. And what they did is they basically looked at pericoronary fat inflammation as can be detected with CT. And they performed a number of studies, which I won't list for you in detail, but you can see the references right here below. And basically what they showed in this study is that signs of inflammation in the pericoronary fat that are associated with poorer prognosis can be detected with CT scans in combination with radiomics analysis of this fat. And if you add this information to traditional markers of high-risk plaque, you can see that there's incremental prognostic value, because if you have traditional markers of high-risk plaque, but also evidence of inflammation of pericoronary fat, you have a 43 times higher risk for a coronary event in the coming years compared to patients who are negative on both of these things. So this is, again, an important publication that shows you that there is more information in the images than we routinely extract right now. And this information can be extracted by using machine learning and AI techniques. Okay, so these were some examples of how machine learning can influence patient care, but what about bringing it to the clinic? So this is the second part of the talk that I want to discuss with you in the last couple of minutes. So there are great algorithms, as we've seen, that can really make a difference, but hospitals cannot work with research algorithms. We know that. They need FDA approval or EMA approval or regulatory approval in your country. So this is a very important, let's say, barrier for the widespread adoption and actually becoming a big bottleneck right now. So this is an interesting article that I recently read. How are America's 5 top hospitals using machine learning today? Well, this is 2 years ago right now, but basically the conclusion of this paper was that they're not using machine learning in clinical practice. I think that has changed right now because I showed you several examples of techniques that are now clinically available and approved by regulatory authorities. So it's slowly coming, but the pace of development is much higher than the pace of clinical adoption. So what are some of these reasons why this is happening? And another conclusion of this paper or this article was that despite the massive investments going into healthcare AI, there is little evidence of hospitals using this in real-world applications. So what are the reasons for this? Well, Roger Kawan from the Harvard Business Review is somebody who has thought a lot about this, and he also wrote a very good article and identifies some issues why AI in healthcare will take a long time to come into routine clinical practice, or at least the way we think about it right now. And one of the reasons is regulatory uncertainties. The authorities don't have a good idea whether or not these algorithms can be trusted and how they should be approved. So they're thinking about that right now, and there's some progress, but that's not as clear cut as for other simple medications or medical devices. There's also a lack of trust by users. And most importantly, there is a lack of validated use cases that shows that applying AI in clinical practice actually leads to better outcomes for less money. So this is probably the most important thing that we need to show before this is going to be used widespread in clinical practice. Now, this is a cardiac imaging meeting, but I want to draw your attention to this paper that was recently published in Nature Machine Intelligence, and this was sort of a meta-analysis of common pitfalls and recommendations for using machine learning in the COVID-19 population. And what these authors looked at is all kinds of different algorithms that purported to be able to diagnose COVID-19 from different imaging modalities. And what they found was quite shocking. And the main conclusion was that in their current reported form, no machine learning algorithm in this review is clinically usable right now for the diagnosis or prognosis of COVID-19. And this is quite shocking. This was a study that analyzed more than 70 studies. And that shows you that we need to really take a hard look at how we design our machine learning studies and how representative they are for actual clinical practice. Another barrier is once we have an algorithm that we believe in and we trust, how do we actually bring it to the clinic? And we've done some thinking about this in Utrecht. So this is a paper that we wrote about how to bring AI to the clinic. This paper is freely available from Insights into Imaging. It lists or it runs down our ideas about how this should be done and how this can be scaled up to accommodate the tens or hundreds of algorithms that we're likely going to be running in the future in our clinics. So this is an example. So we have this running on our clinical PACS system, or in addition to our clinical PACS system, at the workstations in the reading room. So this is an algorithm that segments brain tissue or brain compartments. And basically what you do is if you have a certain task that you want to do, you can run it automatically by setting it up in advance, or you can right-click on a certain study and have it done while you are actually reading a certain case. The results are also visualized. I think that's very important because you want to see some kind of visual feedback with a toggle on, toggle off function to be able to see if the algorithm did its work correctly. This is myself walking through the reading room, and you can see right here that this software actually runs in addition or next to our clinical PACS system. If you're interested in this, this is also an interesting read. It's a report by the Royal College of Radiology from the UK about integrating artificial intelligence in radiology reporting workflows. It's very recent, so if you're trying to do this in your practice, I would highly recommend you to take a look at this document. So let's finish up here, and I think that AI and cardiovascular imaging has a very, very bright future. There are great opportunities for clinically meaningful work. I walked you through the imaging pipeline. I showed that right now, groups of investigators are showing the potential of machine learning in the entire imaging pipeline, from selecting patients to deriving prognostic information. If you want to do this work yourself, it pays to invest in understanding how clinical decisions are made based on imaging and which other information is important, so that you create an algorithm that is actually trustworthy and useful from a clinical perspective. However, what we need to do is we need to keep in mind the generalizability of our algorithms that we create. We need to work on explainability, so which features contributed to a certain classification or diagnosis, and do these match up with what we know about the pathophysiology of certain diseases. And we also need to think very carefully about our workflow integration. And with that, I'd like to thank my collaborators in Utrecht, at the University of Amsterdam, and also at these international institutes. And I would also like to thank my funders of the research. And I would like to thank you for your attention. With that, I would like to finish the lecture.
All right, thank you very much, Dr. Tim Leiner. It's really an inspiring lecture, very interesting and informative. Thank you again. Wow, I'm very much delighted to hear your lecture. And we have maybe 10 to 15 minutes for discussion. So if there is any question from the audience, I checked the chat box, but no question specific for this session. So Professor Tong, you have any question?
Yeah. Yes, so for attending the question from the audience, I have a question to Professor Roshim. Okay, Professor Roshim?
Yes, I'm online. Thanks.
Yeah, do the cardiovascular imaging 24/7 is a department. 24/7 is your department, right? Yes. So how many people do you need for the team when you can do 24/7 for cardiovascular imaging, CT, MR?
Okay. So actually, we do not, in the moment, have a complete 24/7, 365 coverage of cardiac CT. We're still building it up. How many people do you need? Well, you need, of course, a good technician that is trained. One. You need a doctor, a radiologist who has a basic cardiovascular training. And then we work as an interdisciplinary team. So we always have in our emergency department internal medicine doctors who are available for tachycardia control. It's not a matter of between 9 and 5, because then we can do it ourselves. But especially in the weekends or in the very early hours of the morning, it's good to have someone who is able to do cardiovascular resuscitation on a pharmacologic base at that time. So this is a concept. It's an interdisciplinary concept. We will not be able to do it by radiologists ourselves. So it's an interdisciplinary team. We hope to start at the beginning of next year.
Okay. Dr. Lim?
Yes, I have one question for Dr. Joachim, and that is, you mentioned about the very detailed image, very micro imaging, meaning get the image level to the tissue or cell, even to the nerve system, conduction system in the heart. So very exciting. So do you have your own experiment detecting the damage to the conduction system of cardiac system? That is very important. Huh? Okay.
I cited the paper from Stefan Luther, and actually this is one of the things we're doing very intensively. The idea is not really to monitor or to directly image the nerve system because they're too small, definitely. We are trying to look at the consequences of damage to the nervous system by looking at the high speed, high resolution reaction of the myocardium to stimuli from nerves. This is one of the things. That's what I showed with defining the vortices of arrhythmia within the myocardium. And it's more important for the ventricular myocardium than from the atrium. So, but this is basic research. The other aspects, what we do, of course, is simply correlating brain damage or brain disease or neuro diseases with diseases of the cardiac system. It's not so much a matter of resolution at that aspect, more a clinical correlation. So we have two tracks, two levels. One is the very basic research, and there it's more focused on arrhythmia. But if you look at brain-heart interaction, it's more on a clinical base. But it has a huge underneath a huge base on genetic and molecular basic research going on. That's why you're building this special building for heart and brain interaction.
Thank you very much. Professor Leiner, you eventually join this discussion session. Are you okay? Is the internet? No problem?
The internet is a little bit unstable here, so I apologize for that. I'm on holiday, so that also explains my casual appearance.
Okay. Thank you again for your excellent lecture. And I have one or two questions because there was no question from the audience on the chat box. So my question is that you mentioned in the last slide that the universal system for AI applying the ML, machine learning. But my question is that it must be very convenient to have each imager, whatever it is, MR or CT. So the software and machine learning program is embedded to each imager, or is a standalone applying to universal or vendor neutral system? Which way you prefer?
Yeah, so that's an excellent question, I think. And well, obviously in Utrecht, we believe in the concept of a vendor neutral platform. And the reason why we do this is because if you purchase a system from any vendor, at least right now, these systems are semi-locked up, which means that the vendor that you purchase the system from controls what you can put on the system. And that's like buying an iPod or some other music player without a free selection of songs you can put on the player. And that's kind of strange. So I think that ultimately, as a consumer, as a hospital, what you want is you want freedom of choice in what you run in your practice. And that's why we believe in the concept of a vendor neutral platform. And in fact, in Utrecht, what we tell all the vendors that want to sell us their AI algorithms is that we will only consider their products if we can run them on our platform. And that is not very difficult from a technical perspective, because what we do is we basically use so-called containers, which we then plug into the system, which is like an encapsulated software version that the vendor controls. So there's no issues with, let's say, intellectual property or things like that. So we cannot, copy that software or in any sense or things like that, but we can run it and deploy it in the way that we want. And I think that's an important concept that you want to consider if you if you start working on this, because in the foreseeable future, and I think there is a question in the chat by Dr. Bin Lu from Beijing, what is this going to look like in 5 years or 10 years? I think that what we will see is we will have lots of algorithms running. I just showed you a couple of examples. I'm sure that in the rest of the meeting, many more examples will be shown. And, in the foreseeable future, in 5 to 10 years, I think it's very likely that we have hundreds of algorithms running in addition to, the human radiologist, or extending the work of the human radiologist. And therefore, you don't want 100 different workstations. This is impossible. You want a platform that your hospital can control, where you may want to run commercially available and approved algorithms, but maybe you have a group of computer scientists that creates their own things, and you also want to test these things in your let's say, environment. So a platform like that gives you that flexibility, I think. So that's what I strongly believe in, and I'll leave it at that for now to give other people opportunity.
Yeah, I believe that will depend on the proposal using AI. Maybe in a big data concept, we need a separate workstation, standalone. But for each imager, we need embedded into the imager to get the quick result from the imaging each patient. And my second question for you is that last 10 years, maybe from 2015, 2016, AI is full-blown, but as you mentioned, nothing has happened in the real world. So it's very interesting for me. So is it because of vendors or industry part, whatever, is a kind of hype, or is it because of government's strong regulation, or is it in part because of physicians, radiologists, negligence? What do you think about it? What's the main reason?
Yeah, that's also an excellent question, and I think that I think it's not because of the industry. I think the industry has created some really good algorithms that are nice to use, which we do use right now, or are starting to use. Let me put it that way. I think it's primarily there are two big reasons. One reason, like you mentioned, is that the doctors will have to learn how to work with these algorithms. They have to learn how to trust them. And the other one, which is probably more important, is that for many tasks, the algorithms that we have created and have published are simply not good enough to bring to outside of the research environment right now. And many investigators that publish these algorithms, what they do is they don't test them very well in other settings. They test them on a limited set of data from a limited number of hospitals, or maybe even one hospital. And I think we should develop a framework to, let's say, test algorithms. Are they ready for implementation? And this is what the European Society for Cardiac Radiology has recently published. They've published a position statement, which the Asci also co-signed. And I think, when people start developing an algorithm, maybe they should take a look at this document to get some hints on how they can design an algorithm that generalizes to in a better way, so that it's, let's say, more ready for clinical use.
Okay, thank you very much. Professor Joachim, you have any brief mention regarding this topic? Just a brief comment.
Well, you heard the expert, and I just wrote him that I'm always longing to do a sabbatical with him, even now or in his next appointment. I do support this actually totally, because I think in the future we will have different algorithms looking at the same problem. And there are some vendors that actually offer this already. So you put in a chest X-ray or chest CT or cardiac CT, and you get a kind of statistics that tells you about 60% of your 15 to 20 algorithms. They say this is a myocardial infarction, but 3% or 20% say it's not. And so this situation will come. And I think this is very good to support vendors that offer this opportunity. So open platform, definitely. That's what we need.
Thank you very much. Now I will hand microphone hand over to Professor Fan Min Tong for the more question or and closing remark. Professor Tong.
Yeah, thank you. Professor Zhou, yeah, there is another question to you. Dr. James asked you about, do you have a photon counting detector in the market? Do you have photon counting detector in the market?
We don't, unfortunately, because I'm missing a room to do this actually. But the first machines have been sold. And the first machines will be set up in Germany in the next 3 to 5 months. I know one goes to Hanover, one to Bielefeld, to Minden. Another one is actually working in Cheshire, so in Czechoslovakia, in Czechia. So in Europe, the photon counting detectors are distributed. But there is one of the development centers. There's a group that actually works together, and I know that. And there are some in Asia also, but I think the first machines go to Europe.
Yeah. And
the dual source machines extremely expensive. So you got to collect some money from your supporters.
I have another question about tissue decomposition. Tissue decomposition is very new. It's very interesting. It's fingerprinting. It's live fingerprinting. So do you have any experiences about this tissue decomposition, MR, education experiences about it?
So I really didn't get the question correctly because of my internet connection, but I think you're asking me whether we have any experiments or any applications for fingerprinting yet. Actually, we have our congenital or our congenius Martin Uecker in our group still. He's going to Graz, but he's actually working together with a group from California, for Berkeley, on actually fingerprinting. Again, fingerprinting is different in the heart compared to the brain. It's a different approach, and you definitely need very fast algorithms for that to be able to put this. Our first applications, I cited the group from London, but our first applications are more in the liver than in the heart. But it's a next step. So if you're looking at the T1 and T2 mapping was the first try to look at the myocytes, or not the myocytes, but the myocardial tissue, and fingerprinting is the next step because you're getting a lot of problems off with co-registrations of the different images. If you're overlaying T2 star and T1 to do some correction, for example, for iron deposition or copper deposition, this is really the way to go, to have a kind of fingerprinting. It's getting better, consistent results.
Yeah. A question from Dr. Tim. We can do quantifications of epidural facts for cardiac CTAs or MI. What is the best choice?
Yeah, so I tried to answer that question in the chat, and I've seen a few publications on this topic, and all of them seem to utilize convolutional neural networks, which are, I think, very reliable for segmentation tasks. So I think, an approach using such networks should work quite well. And, in the publications that I've seen, the accuracy seems to be very good. So that's what I would recommend. The problem, of course, is that you need somebody to create a training data set, which is a lot of work to get together. So maybe with some medical students.
Okay.
AI will do that, not somebody. AI body will do that.
So, yeah. Okay, there's no more question. So if there's no more questions, so we should close the session. So thank you so much all our speaker, Dr. Rochim, Dr. Tim Leader, for the two lecture. Very, very interesting. Very, it's challenging of cardiovascular and the future. It's really the future of cardiovascular imaging. And thank you, our co-chairman, Professor Ta Wan Lim, for excellent session. Thank you so much, and see you again.
Thank you very much. I enjoyed very much this session. Thank you.
Bye-bye.
Session.
Bye-bye.
Bye-bye.
Take care. Take care.
Bye-bye.
Continue to take a sleep.
To the dreamers who imagine the impossible, who inspire the world with their ideas, and strive to provide clear answers for early and accurate diagnosis, for better outcomes, for better health, for every patient. Bayer wants to join you and make this dream come true.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.